Thank you all so much for joining us for the second session of our new training series. My name is Haley Bell. I'm the training program manager with Telehealth Rocks, and I'll be facilitating our session today. So we're really excited to have you all here for the second session of our new Echo-like training series, supporting the whole child, connecting brain health systems and practice. Today's session is focused on supporting youth substance use prevention and early intervention in schools and communities. And kind of builds on the idea that we can't look at substance use in isolation, but we have to look at the whole child and the systems around them. So we'll really dig into how schools, families, community partners, and care providers can work together to notice early signs, respond thoughtfully, and support young people in a more connected and effective way. Next slide, please. So before we jump into today's session, I do just want to take a moment to kind of reground us in what our series that we have going here is. So it is an ongoing twice monthly learning series, really designed to build over time and is grounded in the whole school, whole community, whole child framework, otherwise known as WSCC. So you hear us refer to that throughout the session. And this model really gives us a shared way to think about how systems connect around children. We also want to make sure that our sessions are interactive. So each session, including today's, will take a case-based approach, kind of making sure we have an environment where we can all learn together and learn from each other. And then the series is also designed to have multiple disciplines and perspectives. So you'll see today that our speakers, Carolyn and Hildy, each bring their own perspective, and we're planning on carrying this model throughout the remainder of the series. And then we'll make sure that everything we talk about in the series, as well as today, is focused on real-world practice and collaboration. So really making sure that each topic that we cover can be utilized in your day-to-day work or life. Next slide, please. All right, so I'm really excited to have the pleasure of introducing our speakers today. So first we have Carolyn Swenson. Carolyn Swenson completed training as a registered nurse, family nurse practitioner, and epidemiologist. And she's also a certified Question, Persuade, Refer, or QPR suicide prevention trainer. She currently provides consultation, training, and technical assistance on SBIRT for prevention and early intervention to address substance use across the lifespan, suicide prevention, and motivational interviewing. She works with healthcare organizations, schools, and other community-based organizations, and is especially committed to reaching underserved populations and under-resourced geographic areas. Her past work includes perinatal, pediatric, and school nursing, public health nursing with migrant farm workers on the Navajo reservation, and in a refugee camp in Sudan. Community-based epidemiology research and quality improvement with clinics, hospitals, and public health departments. And Carolyn was born and raised in Minnesota and currently lives in Denver, Colorado. So super excited to have Carolyn join us today. We're also joined by Hildy Cohen. Hildy Cohen brings a background in psychology, sociology, and education research. She's a training and technical assistant specialist for NORC at the University of Chicago and was the program manager for the development of the adolescent SBIRT curriculum. Her work focuses on substance use and suicide prevention and intervention strategies, with a strong emphasis on translating evidence into practice. She regularly provides training and technical assistance to schools, community organizations, and health systems on implementing SBIRT. And she also co-developed a comprehensive school-based suicide and substance use prevention program training for over 500 school-based staff, school mental health professional staff, and administrators in the best practices around prevention. So together, our two speakers today really bring that integrative perspective that our series is all about. Next slide, please. So really quickly, just a brief overview of our session. This session really is going to teach you all how to identify and respond to youth substance use risk using the screening, brief intervention, and referral to treatment framework and interdisciplinary implementation strategies within school and community settings. And as I mentioned earlier, we are kind of grounding all the sessions in the WSCC model. So today's session hits on the counseling, psychological, and social services component of that model. All right, so before I hand it over to our presenters, just a brief reminder on what our learning objectives for today's session are. So by the end of the session, you should be able to describe approaches to early identification and response to youth substance use in school and community settings. You'll also be able to identify practical strategies for implementing structured screening, brief intervention, and referral to treatment approaches across systems. And finally, you will walk away being able to apply interdisciplinary problem solving to real world challenges that you all are seeing related to youth substance use prevention and early intervention. So with that, I'm going to hand it over to Carolyn and Hildy to get us started.
Thank you, Haley. This is Carolyn, and I'm going to start our presentation today and then hand it off to Hildy. So let's start with, why is this so important? Why is it so important to identify substance use early and ideally even prevent it from ever starting? So first of all, the most commonly used substances among youth aged 12 to 17 currently are alcohol, marijuana, and nicotine vaping. And actually, there has been some good news. Some of these levels of substance use have actually dropped. Others are staying steady, but we know that we cannot stop attending to the prevention of substance use in adolescence. So we're going to talk today about how do we continue to do that and make it a routine part of the care we offer to adolescents in all sorts of settings. Another key thing is that we know that substance use disorders very, very often begin during adolescence. That a person who starts to use any substance when their brain is still developing is at much higher risk for developing a future alcohol or drug use disorder, as well as other major consequences that can harm their health and other parts of their life. Next slide. So the developing brain is a key consideration in this adolescent prevention. The brain continues to develop up until about age 26, which is normal. And because it's still developing, it is particularly vulnerable to substance use. It can have lasting effects on the brain and even disrupt some of that brain development. Different substances affect the brain in different ways. But we know that any substance use can lead to a huge range of problems in young people. Problems at school, strained relationships, physical and mental health concerns, increased risk-taking, safety concerns. And there's two key things to keep in mind about the brain that's still developing in young people. First is that the prefrontal cortex is not fully developed yet, so that part of the brain that's responsible for decision-making, weighing benefits and risks of certain actions is just not fully there yet. And that's why adolescents often take risks that older people wouldn't take. And the second thing is that the adolescent brain is very primed for reward, for stimulation and reward, which is a good thing because it means that an adolescent is very ready to learn new things, try new things. But it also means that risk-taking can be more common and that the brain can be very vulnerable and overwhelmed by substances, and substance use can become habitual quite quickly. And so substance use can increase the risk for so many negative problems, and some of them can be very long lasting. So problems beyond just the risk of substance use disorders. So we know we need evidence-based approaches to address these risks during adolescence. Next slide. So next, let's talk about what is SBIRT. Next slide. So SBIRT stands for Screening, Brief Intervention, and Referral to Treatment, and then we typically call it SBIRT for short. And you can see on the slide a description of what is SBIRT from the Substance Abuse Mental Health Services Administration. It's been around for quite a while, and there's a few things to really emphasize about it. That it's a public health approach. It's an approach that if we apply to the whole population in an appropriate way at different stages of life, we can really make a difference in prevention and early intervention. It helps us find out who's at risk for substance use, who's actually developing a substance use disorder, and help us figure out how can we support people. It's very evidence-based. There's a large body of research now that shows that if we integrate this into different settings, not only healthcare, but also schools, community settings, we can start to make it a routine practice, and we really know that this will improve health outcomes related to substance use in our society. At the same time, we also know that this is still a new practice for many professionals. People in healthcare don't always learn this. Sometimes people in other settings, it's new to them as well, but they actually encounter substance use a lot. So increasingly, SBIRT is being adopted wherever we can help people and identify substance use early and offer some sort of support. Next slide. So let me next describe the components of SBIRT. What do we really mean by screening, brief intervention, and referral to treatment? So the screening part of SBIRT is simply a process of using standardized, validated, age-appropriate questions to identify substance use. Screening does not mean laboratory tests, it means questions. And so some of the screening tools that we use ask about a wide range of substances, any substance use. Others are specific to certain substances, like screening for alcohol use, nicotine, cannabis, or marijuana use, etc. But the screening tools that in order to be useful and widely applied are short, they're easy to follow and score. They're often tools that can be self-administered by a young person or whoever is completing the screening. They can also be administered as an interview. And they're often available in multiple languages, and the tools that are widely recommended do not cost anything to use. The brief intervention is really just a conversation, a collaborative conversation. It does involve providing education and feedback, but it really involves meeting a person where they're at to focus on behavior change and prevention, and draw in the person's expertise on their life and to find out what do we need to provide to support you and help you to avoid substance use problems. And finally, referral to treatment and follow-up is when we link a young person who's at increased risk to specialized supports and services. We do ongoing monitoring. We figure out what issues in their life might need to be addressed in order to support them in not using substances. It doesn't always mean referral to a specialized treatment program, but in some way, we know with adolescents, it's very important to provide services and follow up and monitor and stay in touch with how they're doing. Next slide. So how is SBIRT used? How is the screening applied in different settings? So there's really kind of three categories of types of screening approaches, starting with universal screening. So universal screening literally means we screen everyone. This would be regardless of their risk factors. In a school setting, it might mean all students in a certain grade are screened at least once a year. It might mean that in a certain role or setting in the school, all students who encounter that setting are offered screening. For example, everyone who visits the school nurse for any reason would receive screening for substance use, or anyone who engages with a school mental health professional or a school counselor might be screened. And it doesn't mean every student in the school will always be screened, but it means there's a very universal approach, which has some benefits because it just means you don't have to think about it. It's like, should I screen this student? It's like, okay, we just screen everyone who comes to the nurse's office or everyone in 9th or 10th grade, whatever it is. Targeted screening, on the other hand, sometimes called internal referral-based screening, is initiated when there is some sort of concern that has been identified in a student. That could be from a teacher and a school administrator or another staff member. It could be things like a student is disruptive in class, or they are showing behavior changes. They might be caught using substances. someone is concerned about the student, basically, and it's not clear what the concern is about or what the underlying issue is, but substance use screening would be used to kind of give the full picture of what's going on with the student and how can we support that student and get the right people involved. Some of those folks in school, or perhaps people in the community, or healthcare providers getting involved to support the student. And then finally, indicated screening is where there's already a concern noted around the substance use that's escalating, that a person may be heading in the direction of an alcohol or drug use disorder, but it's not clear that they've actually developed that use disorder yet. But in this case, the screening would be carried out by some designated staff person, such as in a school, to find out what is that level of risk and who needs to get involved and what kinds of services are needed for this student. So there's no one right way to use screening, but this just gives you an example of there's flexibility in how might we apply the screening in the setting where we are working with young people. Next slide. So at this
Great.
point, I'm going to turn it over to Hildy.
Thanks, Carolyn. So I'll share a bit more details about the different components of SBIRT and starting with or continuing with screening. So today we're going to take a look at the craft tool, which you can see on the right here. The craft is an example of a screening tool you can use with youth, and it has been extensively validated and is the most commonly used screening tool for youth age 12 to 21. Just to orient you to the tool, the top part is often known as Part A. It's items 1 through 4, and it asks about the number of days of alcohol, marijuana, illegal drugs, or non-medical use of prescription and over-the-counter medications, and nicotine, including vaping, that have been used in the past 12 months. The middle part kind of is your direction of where to go based on the responses in the top part. And part B is the bottom part, that 5 through 10 items. So these are 6 yes or no items that ask about concerns related to substance use for youth. And this is where the craft gets its name. So you can see all the capitalized words in each of the items. The letter they start with spell out craft, which is helpful. It makes it easy to use and remember. So the first question is the car question. It asks about risk of driving or riding in a car with someone who's been using substances. The R asks about use of substances to relax. The A asks about use while alone. F asks if they forget things they did while using substances. The second F asks if family and friends ever told them they should cut down their substance use. And T asks if they have gotten in trouble while using substances. And the craft is very easy to score. You just add up any yes responses in the bottom part of questions 5 through 10. That score will identify substance use risk along a continuum from lower risk, which would be a score of less than 2, to higher risk, which would be 2 and above yeses in that section. And that includes the risk of substance use disorder. So based on the screening score, you'd provide a brief intervention and or a warm handoff for further assessment and determination of level of care. The most commonly used version contains both these parts, A and B, the top and bottom. But if you're interested in diving deeper into the use of nicotine, the most recent version contains a part C, which asks 10 screening items from the Hooked on Nicotine checklist. And that would be administered for any youth who endorse number 4, so use of vaping for nicotine or tobacco products. And you can see the links in the chat if you want to take a look at the craft on your own. So next we'll talk about briefly the brief intervention. The brief intervention is a short, non-judgmental, structured conversation that can last as little as 5 minutes for those at lower risk, or 10 to 15 minutes for those youth at higher risk. It draws upon motivational interviewing skills, which is a way of communicating with youth using conversational skills, such as the oars you can see at the bottom left. And these are open-ended questions, affirmations, reflective listening, summary reflections that many of you may use in your day-to-day work with young people as well. So these techniques, these MI skills really enhance the internal desire, willingness, and ability for a young person to change by taking a look at their own ambivalence and their own internal motivations for change. BI aims to evoke the young person's those great motivations for change and helps bring out change talk and empower them to make healthier choices about their substance use. As you can see on the top right, we usually have a brief intervention immediately following screening, but a gap or a few days or a week, depending on the referral process there and the procedures you have, won't may not dilute the effectiveness of the technique, but we want to avoid delays as much as possible. Screening and BI can be conducted by the same person or different people, depending on what best fits the workflow where you are. And multiple BIs can be used as well, in addition to a single BI for young people at higher risk. On the next slide, we'll take a look at the brief negotiated interview model. And this is an example of a structured approach to delivering the brief intervention. There are several models. This is the one that we utilize, and it has these 6 short steps with MI skills woven throughout. So during this session, we're going to introduce you to this model at a very high level. Later, we'll provide more links and resources for on-demand learning that you can use to take a deeper dive into these specific steps and how to administer them. But the 6 steps at a high level are engagement. So that's his asking permission to have the conversation about substance use and building rapport with the young person. Step 2 goes into pros and cons, looking at both positive and negative aspects of using substances. And this can really help you as a professional understand why they're using particular substances and help bring ambivalence out into the open. Also hearing the negative aspects in the voice of the youth can really carry a lot of weight. It may be the first time they're thinking about what's not working, what's not good for them about using substances. So that's step 2. And then that leads you to step 3, providing some feedback. It always starts with asking permission to make sure they're open to hearing feedback about their screening score. And then you would share some educational information, such as what Carolyn just shared about the impact of substances on the developing brain. Next, the readiness ruler explores youth readiness to make a change. It reinforces any change is good and encourages youth to share reasons for change and to envision change. Step 5, no matter where they're at, there is an opportunity to negotiate an action plan, even if that's just about following up and seeing how they're doing. But this is a non-confrontational, using non-confrontational advice to express concern. That may motivate youth to develop a plan and make some actions for change. But it's really driven by where they're at, just as SBIRT and as a model on the whole is about where the youth is at. So helping them identify ways that they can reduce their substance use and related risk, helping them identify short-term goals, really concrete steps that they feel are realistic and obtainable. And then the last step is summarizing and thanking. So summarizing using that MI skill to make sure you've captured the conversation correctly, you've got everything right, and you're giving them resources, and certainly thanking them for having the conversation, since it can be very scary and it takes a lot of courage to open up about substance use in adolescence. So, so you provide that thank and schedule a follow-up. There's a few resources we have on the next slide that that are often helpful. So on the left, we have a pocket card which shows a standard drink chart, definitions of binge drinking that are sometimes helpful, and then a condensed version of the BNI steps with some conversation prompts. And then there's another example on the right, which is a fully scripted tool. It's called the BNI algorithm, and professionals can use it as a guide when you're conducting the brief intervention. So the last component of SBIRT is referral and follow-up. Referral is using a warm handoff to link youth at high risk to a licensed substance use professional, mental health professional, or primary care provider to conduct further assessment for substance use disorder, talk further about level of care needed, and or provide specialized treatment or other resources and supports. And follow-up is what allows you to check in about how their action plan is going, their progress is going, and helping them through any barriers to accessing care. Referral is needed when you score at high risk on a validated screening tool, when they're experiencing negative and serious consequences of substance use, when they're unsuccessful in reducing or abstaining from substance use, and youth with co-occurring medical substance use, mental health concerns, such as depression, anxiety, or risk of suicide. That is a situation where it's really advisable to pursue more intensive treatment options and refer to for additional assessments. So with that, that is a very high-level overview of SBIRT. We have a few minutes for any questions, if you have any. And thank you, Lori, for popping in the chat. That you can always pop a question in the chat as we go as well.
Yeah, and feel free, if you all would like to unmute, you can do that and ask a question, or if you're more comfortable putting in the chat, either way will work for us. I know I had one brief question, Hildy, or maybe just one thing you could expand on a little bit. You mentioned the adolescent SBIRT pocket card. Could you just mention maybe a little bit more about how that could, like how that's used?
Sure. Yes. A lot of mental health professionals just have it either. Sometimes it's a full page, sometimes it's a little mini laminated card that they keep on the desk. And certainly, so you'll see there's kind of reasons for, there's some prompts about providing feedback about consequences around substance use. The standard drink charts are really helpful because a young person, any person, can think they're drinking at lower risk guidelines or limits, but have no idea what that really means because, yes, thank you for sharing that. Because as we know, drinks can vary. So a Long Island iced tea is much more than one standard drink. As well as various amounts of hard liquor and things like that. Even restaurants usually pour a 6-ounce pour of wine, which is higher than one standard drink based on the alcohol content. So it can be really helpful to have this card with you when you start talking with the student about how much they're consuming and if they're willing to make a change about cutting back. Just educating them on what really is one drink is very important because that can vary widely depending on the actual cup they have. They are saying it's one drink, but if it's a 16-ounce cup, that is very different than a small 8-ounce cup. So folks use that, and then the just these prompts for the steps are really helpful when you're walking through.
Hildy, can I add one thing about the pocket card?
Yes, please.
Having worked on it. So with the other thing I think that's actually really important that the pocket card tries to highlight is that what are the binge drinking levels in adolescents? And they actually vary from what are binge drinking in adults, and they vary by biological sex. So for example, younger girls, and the binge drinking meaning the level at which you become intoxicated, will become intoxicated generally if they have 3 or more drinks in about 2 hours. And that stays the same all the way through about age 17. And because adolescents who drink alcohol tend to binge drink, it's really important that we help them understand what is that. And that's when you have an extremely high risk of really negative things happening, like accidents, injuries, being taken advantage of, for example. So I just wanted to add that because we've learned that people don't necessarily know that adolescents are different in their response to alcohol, and a lower amount of alcohol can create intoxication in an adolescent.
That's super helpful. Thank you both for kind of diving in a little bit deeper to that. I haven't seen
Great,
any
thank
other
you.
questions come in the chat. I just want to check one more time if anyone has any questions so far for Carolyn and Hildy before we move on to the kind of case portion of the presentation. I think we're a quiet group today. If you guys think of any, feel free to put them in the chat. And if we have some time at the end, we can always come back to those.
Mhm. No, that's great. We'll move to the case discussions, and sometimes these can really get your wheels turning because we're really going to talk about some scenarios. And when you start thinking about how SBIRT might be implemented in your setting, we, would love to hear questions around that come up. So we're going to talk about some cases that we've experienced, perspectives from different disciplines, and we'll have some questions after each component. So we're going to go screening, brief intervention, and then referral to treatment. And then we'll encourage you to share and gather ideas that you can take back to your organizations and settings for implementation. So we can go to the slide before and we'll walk through the scenarios. So the school A scenario, this one is implementing a targeted screening approach in which the school personnel refer to a designated school professional. So a student here, as you can see, who is charged with some vandalism. They were referred, that was their first offense, and they were enrolled into a support program, and the school administrator conducted an internal referral using that warm handoff to the social worker in the school who administered the craft, and the students did screen positive for substance use risk. So overall in this scenario, this does come from a large school district implementing district-wide. It was geographically diverse, urban, suburban, rural schools. And the district really wanted every school social worker to have a standardized process, including the craft. And you can see here as well that the district wanted to use a targeted rather than universal approach. So sometimes we call that our SBIRT, referral first to someone to do the screening and the SBIRT model. And then here, what's not pictured is that some districts do require parental permission for screening and or the entire SBIRT process. So that will vary depending on school policies and procedures of how to handle parental permission. That gives you a bit of an idea in that scenario, and I'll hand it to Carolyn.
Yeah, so school B, the second scenario that we'll discuss, is a school that implements universal screening. And the universal aspect of the screening is through the school clinic, like the nurse's office or a school-based health center, which is something where every time a student visits for any reason, they are screened with SBIRT, with probably the craft or another tool, but often the craft. And so in this scenario, we have a student who visited the clinic because they've been feeling sick for several days. They maybe didn't have a lot of specific descriptions of how they feel sick, but maybe just not feeling right. Maybe their stomach feels sick, they have a headache, but one way or another, they're just not feeling right. So the nurse, as just part of the universal process, asks the craft questions as part of the intake process. And this student, and of course, making the student feel comfortable, so the student did disclose that there was some substance use in the picture. And we'll talk in the next section of this case discussion about how much risk is there. But basically, the nurse identified some concern, and that nurse then made a warm handoff using telehealth to a community health worker, someone who, probably is connected to the schools in some way, but also works out in the community. And that community health worker has great rapport with young people and is trained to provide behavioral intervention, since that's such a common need in youth. And also she knows the community, or she or he knows the community, or they know the community, in order to be able to find programs and support options to help navigate that care process for students and families. So this is really a very meaningful approach to screening because, well, first of all, substance use can affect so many aspects of health. So when someone in a role like a school nurse encounters a student, sometimes it's very clear what's going on. Is there an asthma attack happening? But on the other hand, is there been an injury? But why did the injury happen? Could substance use be in the picture? Or a student who's just not feeling well and it's just not typical for them, or the teachers might even notice they're drowsy in class or something's just off about them. And so although the nurse may not be in a role of diagnosing a health condition, by screening for substance use, the nurse can get a much bigger picture and more accurate picture of what could be going on with this young person, because we know substance use can very often be in the picture, but we'll miss it because it might not be at the level of a really sort of classic alcohol or drug use disorder at that point in the young person's life. So that's the second scenario that we'll discuss as a possible way to use SBIRT in a school setting. Yeah. So next we go on to some discussion.
Yeah, we'd love to open it up for a few minutes and hear how, where, and when screening can happen in your setting. So you can respond to any and all of these. So what would screening look like in your setting? When and where could it occur? Who would do it? And what advantages do you see in embedding screening in this way?
And again, feel free to respond in the chat, or if it's easier to come off mute, we're happy to have you kind of share that way as well. I did see whenever people introduced themselves in the chat that we do have a few different school social workers and some other individuals in school roles as well. So we'd love to hear from you guys.
What questions or concerns might you have about bringing this substance use screening process into the picture when you're, encountering things that tend to happen day to day fairly commonly in school settings or another community setting?
I can share really briefly. We have a number of community health workers that Telehealth Rocks works with. And so I think we've heard kind of across the board and from other partners that some concerns would be kind of not knowing how to do it the right way, or, bringing more harm than good whenever kind of approaching this subject. But I do see we have some other responses in the chat now as well. Some worry about the liability of screening students by the school and the obligations once they screen as well.
Yeah. Yeah, so there typically are, upfront things to figure out as far as parental consent and opting in or opting out of screening. But many schools now, and I know Hildy, you've worked with many schools, have figured this out. So there are definitely models out there for how to make this happen. And there's a lot of answers to the questions that typically come up. So yeah, that's all. I'll start off with that, but Hildy, you may have a lot more input on this.
Yeah, it's definitely a collaborative effort to work with leadership, administration, school board, and to take a look at the policies and procedures that the school or district currently has, and talk through, based on if there is a requirement for parental consent, what that workflow looks like you said, the opt-in or opt-out is very popular, either sending, in terms of sending forms home for parents and caregivers to complete. But it definitely takes that, like you said, some work up front with leadership to um, identify how the process is going to be implemented. And that is one of the biggest things that reduce liability, because having a process in place means that if you're documenting that you're following it, then you are, you know, addressing a student concern in a standardized way. And that's what a lot of school districts want to put in place, is that formalized process to keep students safe.
When I've worked a lot with nurses, but also and social workers, I think it's important also to emphasize that when you administer expert screening, you are not making a diagnosis. You're not taking on this clinical role of diagnosis. And for school nurses, it's like if someone shows up in the school nurse's office or at a school-based health center, you start with things like vital signs and some basic, kind of triage type questions. And that essentially is kind of how you can view the expert screening too. It's like, we might take your temperature and your blood pressure, ask you a few common questions about what's going on. But expert just provides a more structured way to get at the substance use issue in a way that's been shown to help students feel more comfortable disclosing, but also is not taking on the role of diagnosing, but identifying, hey, there's a concern we maybe should think about as part of the big picture when we're looking at this student's needs. I hope that helps.
Yeah, it looks like we had a question in the chat too. Farah was curious if either of you have ever seen students that responded by actually wanting to be above average, either with substance or alcohol use during the screening process.
That's an interesting question. Yeah. Hildy, do you have any thoughts about that?
I haven't seen examples of that necessarily, but Carolyn, I'll pass it to you.
Yeah. Well, I think if I'm understanding the question right, like sort of if it's like almost like boasting of, then that I'm very accustomed to substances, it's no big deal. I get more often the question, are people honest when we ask these questions? And what I always say is, first of all, we always begin with whatever a person's willing to tell us. And then we don't we try very hard not to assume that they're misleading us because it's it's a sensitive topic. I also feel like it's important on the first part of the craft to recognize that when you do that sort of introductory on how many days have you had alcohol or another substance, it's not really meant to be an accurate accounting of literally how many days, but rather a way to make it comfortable to disclose any use. Some people have maybe tried alcohol or cannabis or tried vaping, and it's easy then to say, oh, a couple times. Whereas if it was just a yes, no question, it can be more uncomfortable to acknowledge, yes, I have engaged in some substance use. So I think whatever the student offers to us, we take that, whether it's a very large amount of substance use, it almost sounds like, they're trying to exceed what the average student might drink with their drinking alcohol. We take it and work with it and try to understand their perspective, their specific situation, and always appreciate that they're willing to disclose anything to us. I hope that's a great question, and I'm curious to think more about it, but I hope that helps a little bit.
Yeah, Farah shared some additional context that she's kind of heard those responses on different college campuses. So maybe they may have promotional materials kind of talking about what an average amount of drinking per day is. And then maybe those students responded by kind of, expressing that they had more alcohol or substance use than even what was on the material shared.
Yeah. Yeah. Well, a major part of decreasing risk is to talk about whatever they literally are consuming and talk about what would it look like to decrease risk by, ideally not using the substance, but definitely decreasing if they're not interested in completely stopping. Yeah.
I do want to highlight too, Lauren had a great comment in the chat. She said, I think anytime we can integrate or embed screening into our work, it helps to destigmatize the practice. So I just really appreciated that comment, Lauren, and wanted to share that as well.
Yeah, and I'm seeing this other comment that yes, peers often, or young people often overestimate what their peers are, how much they're consuming of alcohol or another substance, and young people often also way overestimate how many of their peers are actually engaging in substance use. And so we call that normative feedback, where we can say, actually, most of your peers aren't drinking alcohol or using marijuana. But, we always, again, start with what they have heard, what they believe, and what they report to us about their own use.
Yeah, great comments. Great questions.
Yeah.
Maybe we can take a look at the brief intervention scenarios and dive in a little bit deeper here as well and hear your thoughts. So overall, for the school A scenario, so that student that was referred to the school social worker for some vandalism received that brief intervention. The student scored a score of 1, indicating that lower substance use risk on the craft. They said that they were at risk of getting in trouble for their use. And so that BI that the social worker provided was focused on building awareness and reducing risk. And they didn't hear anything about co-occurring risk. They did hear some concerns about getting along with family members at home. And the student had some concerns about having enough food or access to transportation. So that kind of gives a picture of the BI that was provided. And I'll turn it to Carolyn for the B scenario.
So in school B, so the nurse has conducted screening using the craft and also learns a little bit more about the presenting concerns, what the student's not feeling well, what's really going on, gathered some more information, and does identify that there's some substance use in the picture that needs to be addressed. And then this nurse conducts a warm handoff to the community health worker, sharing information. There's clearly some agreement already in place to be able to share information and expressing the concern that the physical symptoms that the student is describing are very likely related to the use of alcohol and marijuana. And this student scored at a 2 on the craft, which, as a reminder, at 2 or higher, that indicates a higher substance use risk and a need for some sort of referral for further assessment and services. In other words, we don't wait any longer to support this student. And in fact, sometimes this is one of the surprising things about SBIRT is that with young people, we really want to intervene as soon as we recognize that there's either escalating use or a higher level of risk. And so the community health worker is going to conduct a brief intervention, or does conduct a brief intervention, focused very much on meeting the student where they're at, exploring with the student what steps are they willing to take to reduce their risk, and openness to receiving further care and assessment. And this is all done over the phone. The caregiver, or I'm sorry, the community health worker also engages with the caregiver with permission of the student by phone. So this has, a brief intervention has occurred outside of the setting where the screening actually took place. And you can see it started to get the caregiver involved as well, since we often know that students with a higher level of risk, especially in those cases, will need support of a trusted adult in their life as well to get the help and support that they need to address the substance use.
Great.
So,
Oh, I see a few comments coming in. We'd love to hear similarly what the brief intervention might look like in your setting, where, when it might occur, who might do it, advantages, and seeing, some evidence around SBIRT's popularity and effectiveness. So thank you, Ashley, for sharing that. And um, yeah, great point. Great point. Any other thoughts about where the brief intervention might fit, or questions?
Just gonna pop off chat and just see if you could speak a little bit to the utilization of SBIRT within the alternatives to suspension sort of framework. I think that might be an interesting piece on that kind of more targeted intervention.
yeah. Hildy, do you want me to start?
Sure.
Yeah, so that's a really good point. And I think SBIRT is being incorporated more and more into alternatives to discipline approaches in school, making it a really part of the protocol. And what I like to talk about is making it about health first as well, so that, as soon as there's someone that's, broken a school policy, gotten in trouble, that we always consider what's going on with their health. And of course, substance use is part of health. And then offering to students, and sometimes families get involved in this as well, as a policy or protocol that can be followed to try to really help the student get the help they need around the substance use, but also stay engaged in school. Because as soon as we exclude kids from school, it sends them on a trajectory that can be really harmful to their future academic success, and even a lot more things in their life can be harmed. So definitely SBIRT fits in the alternative to discipline model. I guess I didn't see any other questions on the BI, and I think we want to keep moving, but I just also wanted to say that we can emphasize that many different disciplines can conduct brief interventions. It doesn't have to be the licensed person, or it doesn't have to be the health person all the time. Anyone who can have good rapport with young people can learn the skills of doing the brief intervention, and then figuring out what next has to happen, and when do we need perhaps a more like a licensed person to get involved. But you can think very widely and creatively about who could do brief interventions in whatever setting you work in.
Yeah. And I know we're getting close on time, so just very quick run referral. You can see from School A scenario that student didn't have indicated need for further substance use assessment at that score of 1, but had some needs for referral to some resources for food, transportation, and follow-up. This is a case that really highlights that the next step here would be checking in with the student within a period of time to see how they're doing, make sure things haven't changed for them around their substance use.
Yes, and in School B, so now the brief intervention has been conducted via telehealth, and the community health worker recognizes that there's a need for a warm handoff for further support and assessment. And so the community health worker connects the student to a local physician, ideally probably their own primary care physician if they have one, for further assessment. Also shares information about how to find treatment services. There's a free national provider locator, directories of services throughout the country that can be useful to find out where are there services, what insurance coverage is needed, and do they take care of adolescents, for example. But the community health worker also, in addition to that care navigation, schedules follow-up, because we know ongoing monitoring, checking in with a student is critically important. So, it's taking multiple people to get the student the help they need. And it also means that we hope that local health providers, like the local pediatric provider, family medicine provider, school-based health center providers, are also familiar with ESPER and with managing substance use needs in young people. But that's what would be happening with student B, who, remember, is higher risk, and we don't want to wait to give them further support to address the substance use.
So I think we'll probably pass it back to Haley to wrap up, knowing that, that we'll have a lot of resources around the referral step that you can take a look at it as well.
Yeah, of course. So just kind of covering really quickly, I know we're wrapping up towards the end of the hour, but as you saw through the presentation today that Carolyn and Hildy gave us, youth ESPER really can be seamlessly integrated into school and community settings with trained professionals from all different roles. So I really liked that you guys mentioned, the idea of community health workers, but also really just emphasizing that it doesn't necessarily need to be someone with a clinical background. And then we've got some different readily available ESPER tools and resources that are no cost that I have linked here in the chat for you all. And then there is also an additional adolescent ESPER on-demand training at no cost as well. I don't know, Carolyn or Hildy, if you had any additional information on that specific training that you wanted to briefly share.
No, thank you for popping the links in. They're free to access, lots of great information there. And there's a quick form just to complete, but it'll take you right there. We don't collect any information for any other purpose, but to track who utilizes and accesses, how many people kind of access the training. So yeah, freely available for you all.
Thank you so much for sharing those resources. I'll go ahead and have you move to the next slide. So I really just want to start by saying thank you so much to Carolyn and Hildy for sharing their expertise today and kind of giving us that overarching view of what ESPER is and running us through those case models. I do just want to highlight our next session in the series. So this next session will take place on Wednesday, May 13th at 9 a.m. Central. And the topic is going to be preventing and addressing youth gambling behaviors, which is an issue that we've been hearing from many of you and from our other partners. So really looking forward to that. We hope you will join us as Ken Winters and Jerry Bauer-Kemper kind of take a deeper dive into that topic. And then finally, I just want to thank you all for registering for the series and for being here today. As part of that, we would love to get your feedback on today's session. So I've got a link I'm going to drop in the chat. And then that QR code is there as well. And this will just take you to a brief post-session survey. So really just your opportunity to share with us your thoughts and experiences in today's session. Like we said, this is a newer series, so really looking for your input on how we can make this time the most meaningful and valuable for all of you. So you will get that link in the follow-up email, as well as the resources that were shared today, a copy of the slides, and a copy of the session recording. So again, I just want to thank you all so much for joining us. We really appreciate your time and look forward to seeing you at our next session on May 13th at 9 a.m. Thank you so much. Have a great rest of your day.